Thank you all for those presentations. We have about 10 or 12 minutes for some discussion here, and we have a few questions. I'm going to take the prerogative of the chair and open it with a couple questions. Before I do that, though, I do want to call out the National Academy's staff who have worked with us very closely over the past many months in putting together and organizing this workshop, as well as supporting it today. Emily Zevon has been perhaps the lead, but Cindy Trang, Carol Sandoval have helped, and you heard from Cheryl Nass earlier, who has also been key to putting this event on. So to all of the National Academy staff, thank you so much for your hard work and help in organizing this event. You just heard from Adrian, so I'm going to actually ask him to lead off this, but then I would also ask Drs. Kirsch and Matthews to also comment that if you had to pick 2 or 3 things that define good access from a veteran's perspective, what might those things be? I mean, Adrian made the point, as did Cheryl, that access is a critical component or element of high quality care. So with that in mind, how do you think veterans view good access, or from their perspective, how would you characterize this in just a few words? Adrian, then we'll go to Cameron and Susan.
So thank you. That's a really good question, Ken. I think that the best example I can give folks on this that are watching this workshop is the Spinal Cord Injury and Disease Center. Veterans who have this traumatic, catastrophic disability go through a very intense rehab through the SAI centers that VA has, and they establish very strong bonds and relationships with the clinical team. Throughout their life, they will end up traveling across the United States, but they go back, no matter where they live, to that one SEI center. They will travel. They'll make their time and pay the way to get there because of that relationship. I think access really comes down to the personal preference of that veteran. Some of it is very strong and some of it is not. And I think it's imperative that the VA understand and somehow capture this if we are to assess and reform measuring access and optimizing access to care.
Cameron, what do you hear from veterans who go to the community? What does good access look like from their perspective?
Yeah, thanks for that. And I think Adrian said it exactly, really how we're also trying to approach community care, the larger concept of continuity, of connection with a provider, whether it be primary care or any other specialty services, I think is the critical piece that must be maintained. And unfortunately, with the history of community care the way it's been, we've just had a lot of transitions of networks that have unfortunately not been optimal and veteran-centric at all. But really, access to me is making sure that we have available services and that veterans have a connection to their provider, and that it not be an all or none concept, that they can take part in VA care, that they can take part in community services, and that there be integration between all of those services. And I think that's also a piece that has been difficult in the past. But as we look at interoperability of our EHRs, other ways that we can share information and transitions between emergency room, inpatient, outpatient, I think that's a large piece of access that's necessary, because the ability for multiple members of a care team, regardless of whether they're VA providers or not, the ability to take care of a veteran really hinges on those capabilities of communication. And I think we have we've made a lot of progress, but there's still a lot of room to go. But that being hinged on veteran preference of provider and continuity of care with regard to those relationships, I think is just as important.
So, Dr. Kirsch, seeing access within the VA, what do you hear from veterans as far as what good access looks like?
Oh.
Are you muted?
Yes, sorry about that. You didn't hear what I was saying. So, as Dr. Matthews just said, it is a large integrated network. It's more integrated in some areas than others, and we really need to continue to press forward and identify ways to measure that and lean into the coordination component, as Dr. Matthews just said. And as I'm listening to Adrian and his eloquent presentation, I really thought a lot about one of the roundtable findings, and that some of this isn't just about a number or a measure and how many days. It really is about truly capturing how the veteran feels about getting a service. If they felt good about it, it met their need, it addressed what they were worried about. And so as I continue to think about this and this workshop, I want to continue to have that voice as a part of it and of the veteran and what they want out of this. So that's what bubbled up for me. So that's what I just shared. If there's anything further, let me know.
Yeah, and I think one of the most powerful and insightful observations that came out of the roundtable was this issue of does the patient, in this case the veteran, do they feel that the system actually cared about them and did it meet their need or their issue, whatever that happened to be, which may not necessarily be what's listed as the chief complaint on the form. And, there may be multiple ways of meeting that need and demonstrating that we actually do care. And I think that's something we'll hear more about in some of the other sessions as we go forward. Let me pose a question, and anyone who wants to can respond to this, but I think this is probably going to go to either Drs. Matthew or Kirsch. The question was asked, how is VHA ensuring that urgent care facilities and other community care providers are coordinating with VA-based primary care physicians and preventing disruption of continuity of care? And this is an issue that we've talked about a lot, about fragmentation of care, because we know that fragmented care is not good for quality of care. So whoever wants to jump in there.
Yeah, I can definitely take that. We still have a long way to go with regard to this coordination. We have instituted, even in the last year since the Mission Act has been deployed, we've instituted new IT systems that allow for more streamlined and asynchronous communication between care teams. We have a health information exchange that, of course, is transitioning over to the Cerner world as we make that transition as a national health system to the new EHR. But our other IT systems allow for, of course, direct secure messaging. Our referral system allows for also communication as well. But I definitely see there's plenty of room for growth in all of these respects. I think it's been difficult to actually have assurances beyond really the sharing of medical records, to be honest, mainly as we are deploying new networks, improving really our role as a partner. VA, as many of you are aware, we've had difficulty in paying our bills with regard to the care that's provided in the community. And as we really improve those services, we will be looking towards more requirements of coordination so that there can be better assurances. But as of yet, we really are relying really on the professionalism of our providers in the network to share those medical records and to assure that information about urgent care visits and the like are shared back with the VA team. One of the difficulties, of course, is knowing which VA provider to get in touch with, even sometimes which VA facility. And so we're really improving as much information with regard to points of contact through our website. And then, of course, the new IT systems can streamline some of that communication as well. But ultimately, the interoperability and health information exchange of the new EHR is going to be the most efficient.
All right, we have questions. I'm going to try to get 2 in before we take a break. I'm mindful of the clock, and we will need to take a short break so that we can transition over to a new set of speakers and the next panel. But so I would ask that whoever responds to this do so succinctly. So one of the other questions that has been raised is, how does VA reach out to homeless veterans and measure their access to care as well as their continuity of care? And having chaired a prior National Academy's consensus study on looking at homelessness, I'm interested to hear the answer to here because I know how complicated it is. But who wants to take that? Susan, do you want to jump in on that one?
And I can certainly jump in and state that there is a homelessness office, and I know I can in the break in short order get a response of confirm some details, but the continuity is a very high priority, as you would imagine, and I know that they do have outreach, but getting those specifics, I want to ensure that I'm correct, and I want to reach out to that dedicated office to address this.
All right, so we'll put that one on hold to come back to a little bit.
Absolutely later. Will. Yeah.
And obviously, homelessness and dealing with homelessness is often described as the VA's 5th mission, even though it's not statutorily mandated, but because veterans constitute such a large portion, or at least historically constitute a large portion of the homeless population, it has been a particular issue for VA to deal with. So let me pose one other one. How does VA currently utilize access metrics to proactively curate its outside specialty preferred provider network? And is there an annual centralized systematic review process? Cameron, do you want to try to take that?
Yes, definitely. So we actually do not evaluate the individual providers in the network, where instead we have a network adequacy requirement for our third-party administrators who are responsible for the network. So not on an individual provider basis, but across the network, access is expected to be met with regard to specific drive times and wait.
All right, so again, trying to keep things on schedule, there were some additional questions that were asked. We'll try to get back to them later. We'll save them and see if we can come back to them later, as well as some comments. One of the areas that we really didn't get to touch on in this session, but we'll be coming back to it, is how has COVID changed things, and how are we rethinking about access in a world where we have this new, which didn't exist when we were originally planning for this workshop. So with that, I'm going to call an end to session 1. We will take a break for about 7 or 8 minutes and then reconvene with session 2, where Dr. Andy Beinman from UCSF will be the moderator and lead us through a panel and discussion on some of the strategic considerations in conceptualizing access to care. So if folks could just stand by for a few minutes, we will start again in probably just 5 or 6 minutes from now. Try to keep us on schedule. Thank you.